Well, hello and welcome to this month's podcast where we will bring you up to date, as always, with the latest information and data in the world of rheumatoid arthritis. And it's a special pleasure, I have to say, to be joined today by a fellow member of the IMID Forum Steering Committee, Professor Hans Bijlsma. He's Emeritus Professor of Rheumatology at University Medical Center Utrecht, the Netherlands. Hans, it's wonderful to have you along. Nice to see you.
Thank you very much. It's a pleasure to be here.
And so Hans is one of my favorite people to spend time actually talking about all manner of interesting things. Today we get to sit and talk to each other about matters rheumatological. And particularly we're going to discuss a couple of papers by Maya Buch and Yoshi Tanaka, in which we're comparing the efficacy and safety of Filgotinib and lymphocyte count and infection risk associated with Tofacitinib, again in people with rheumatoid. And of course, before we launch into papers, remember please that you can access detailed summary slides for the papers we're talking about today at imidforum.com. So that's imidforum, all one word, .com. It's a fabulous resource. Pop over there, see what there is to be found: abstracts, slides, presentations, and podcasts. So we're going to turn to the first paper, and Hans, I think you're going to take us through this one. Over to you. Thanks.
Sure. So the first one is dealing with efficacy and safety of Filgotinib in patients with moderate active rheumatoid arthritis and an inadequate response to methotrexate. Well, some background of the study. Filgotinib is a Janus kinase 1 inhibitor for patients with moderate to severe active rheumatoid arthritis who did respond inadequately or intolerant to at least one disease-modifying antirheumatic drug. This post-hoc analysis assessed the efficacy and safety of Filgotinib in combination with methotrexate in the subgroup of patients from the Phase 1 trial with moderately active rheumatoid arthritis and who had an inadequate response to methotrexate based on the DAS-CRP score between 3.2 and 5.1 at baseline. So let's have a look at the results. In these patients with active moderate to severe rheumatoid arthritis and an inadequate response, as mentioned, received Filgotinib 200 mg or 100 mg once daily, adalimumab 50 mg every 2 weeks, or placebo, all combined with methotrexate, and the total number of participants was over 1,700. Baseline characteristics were similar across treatment groups, with an overall mean duration of rheumatoid arthritis of 8 years and a mean DAS score CRP of 4.6. The ACR20 response at week 12, which was the primary endpoint, were 78% for Filgotinib 200 mg, 68% for Filgotinib 100 mg, and 44% for placebo. More patients receiving Filgotinib 200 mg or 100 mg and adalimumab achieved the ACR20 response at week 12 and 24 compared with placebo. Response rates were generally comparable between Filgotinib doses and adalimumab across all weeks. An incremental benefit of ACR 50 and 70 response was observed with Filgotinib treatment over time, with both Filgotinib doses maintaining efficacy up till week 52. A higher proportion of patients achieved DAS-CRP response below 2.6 or 3.2 and CDI remission or LDA with either Filgotinib dose compared with placebo at weeks 12 and 24. Response rates were generally comparable between adalimumab and Filgotinib. Less radiographic progression was observed with Filgotinib compared with placebo. However, radiographic progression was numerically similar between adalimumab and Filgotinib 200 and 100 mg at weeks 12 and 24, and between adalimumab and Filgotinib 200 at week 52. Incidence of treatment-emergent adverse events and serious treatment-emergent events was similar across all active treatments. In this subpopulation, I think we are now reaching some conclusions. In this subpopulation with moderately active rheumatoid arthritis, efficacy and safety of Filgotinib were similar to those in the overall Phase 1 population. to note that Filgotinib 200 as well as 100 mg elicit greater improvements in disease activity than placebo. Filgotinib resulted in numerically lower radiographic progression, and therefore I think the overall conclusion would be that data support consideration of Filgotinib for the use in patients with moderately active rheumatoid arthritis.
So thanks, Hans. We'll get on to the next paper just momentarily. I guess the obvious thing to ask you is anything here that really surprised you?
Nothing at all. I think this was a clear view already emitting from the previous studies that have been published. So in fact, it is a post hoc analysis collecting all the data together.
Yeah.
But basically, it confirms that Filgotinib is a real alternative for treatment in active rheumatoid arthritis.
Yeah, that was certainly where my thinking got to. No, listen, thanks. So I think, and for those of you listening to the podcast, this is not unexpected, but still valuable contribution to literature because we need to understand what these data are. And I don't think we should make the assumption that every JAK inhibitor is created the same. In the long term, we're starting to see some very common features emerging across the different drugs, but it's always important just to make sure that we confirm that rather than imagine such evidence. So, Hans, why don't we just crack on and hear the second paper? Thank you.
Yeah, it's quite a different subject.
Yeah.
It's looking at the relationship between lymphocyte count and the risk of infection in a special group of Japanese patients treated with Tofacitinib. So we changed the JAK inhibitor to Tofacitinib. So some background again to start with. We all know that infections, and especially herpes zoster, are common and may cause death in patients with rheumatoid arthritis. Especially those treated with Tofacitinib, which carries roughly a twofold increased risk of especially herpes zoster infections compared to the biological DMARDs. We know also that treatment of Tofacitinib can lead to treatment-induced lymphopenia, especially at lymphocyte counts of below 500 cells per cubic millimeter, which are linked to an increased risk of infections, especially also herpes zoster. If we look at patients from Japan with rheumatoid arthritis treated with Tofacitinib, we see a 2 to 3 times increased incidence of herpes zoster compared to the global populations, possibly due to a lower lymphocyte counts, but also there might be other factors such as genetic and environmental. So this is a post hoc analysis characterizing changes in absolute lymphocyte counts, but also in some lymphocyte subset counts in patients enrolled in phase 2, phase 3, and long-term extension studies from Japanese centers in the Tofacitinib rheumatoid arthritis clinical program. The authors evaluated correlations between absolute lymphocyte counts or lymphocyte subset counts and the risk of serious infections, especially looking at, as mentioned, on herpes zoster. The absolute lymphocyte counts and lymphocyte subset counts were assessed in 3 cohorts based on the availability of the data. The first cohort, the biggest one, including over 750 patients, assessed absolute lymphocyte counts over 75 months in these patients receiving different doses of Tofacitinib, namely 5 mg twice daily, 10 mg twice daily, but also the modified release 11 mg once daily. Absolute lymphocyte counts data was collected at baseline and at 3 months intervals as part of the safety monitoring. The second cohort, cohort B, was a subset of the first cohort A, focusing on lymphocyte subsets also over 75 months in patients from phase 2 and long-term extension studies. Lymphocyte subset counts populations included T cells, B cells, and NK and NKT cells collected at baseline at month 3 in phase 2 studies and up to 4 times from each patient between March and November 2013 in the long-term extension study. Then the last cohort, cohort C, over 200 patients, examined short-term absolute lymphocyte counts and lymphocyte subset counts changing over 3 months in Japanese patients receiving TOSA 5 mg twice daily or 11 mg daily. Lymphocyte subsets were defined in greater detail, distinguishing CD4 positive and CD8 positive T cells among other subsets. Now looking at the results. It's important to note, because of the influence of glucocorticoids, that the lower percentage of patients were on concomitant glucocorticoid use in cohort C compared with the other cohorts. That may influence the results. In cohort A, the proportion of patients with an absolute lymphocyte count of lower than 500 cells per cubic millimeter was generally only less than 2.5% from baseline through month 75. So not a very often occurring problem. The proportion of patients with an absolute lymphocyte count of more than 1000 cells per cubic millimeter at baseline, month 1, month 3, was 90%, 93%, and 87% respectively. Important to note that no patients in cohort C demonstrated an absolute lymphocyte count of less than 500 cells per cubic millimeter across all observed time points. In this cohort, in cohort B, Tofacitinib treatment was associated with a numerical change from baseline in T cell counts of 200 positive and minus 130 per cubic millimeter at month 3 and 6 respectively. Moreover, lymphocyte count subset counts were generally stable from month 36 to 75 in cohort B, although interpretation of changes observed at some time point was limited due to low patient numbers, notably below 10. In cohort A, the incidence of serious infections was similar in patients with confirmed absolute lymphocyte counts above 500 cells per cubic millimeter. In contrast, incidence of serious infections was numerically higher in patients with confirmed absolute lymphocyte counts below 500 than other absolute lymphocyte count categories. Incidence of herpes zoster was highest in the group with less than 500 cells per cubic millimeter, which is exactly what was expected. Baseline absolute lymphocyte counts and lymphocyte subset counts were generally numerically similar in patients with or without serious infections or herpes zoster, but to note, the numbers of patients were small. So that leads to the following conclusions. Absolute lymphocyte count remained generally stable over 75 months. It's interesting to know an initial transient increase which returned to baseline at about 18 months. The highest risk of serious infections and herpes zoster in Japanese rheumatoid arthritis patients on Tofacitinib was observed with absolute lymphocyte count below 500 cells per cubic millimeter, supporting this threshold as clinically relevant. These findings recommend an absolute lymphocyte count monitoring at baseline at every 3 months, avoiding Tofacitinib initiation if absolute lymphocyte count is below 500 cells per cube, and discontinuing if levels drop below this threshold. Therefore, Japanese patients with absolute lymphocyte count below 500 cells per cubic millimeter may have a higher risk of serious infections and herpes zoster compared to the global populations. Further research in a larger population is needed to confirm correlations between lymphopenia and infection risk in Japanese patients with rheumatoid arthritis treated with Tofacitinib.
Fantastic. A lot of data to get through there, Hans, and you did it beautifully. Thank you. You know, I've been thinking a lot in the last while, prompted, well, for many years, about something we've often called the immunological stethoscope. That is some measure of how functionally competent is the immune system. Could we listen to the immunological chest and hear the heartbeat of the immune system? How well is it functioning? Because you know, we measure numbers of cells instead of their cellular functionality. And I think one of the reasons you need large populations, and I think the authors are right to pull out this need for further research. I suspect not only do we need to look at larger numbers of patients, but we also need a far more sensitive measure of how competent the immune system actually is in a given scenario. So that I think the number 0.5 times 10 to the 3 cells per milliliter cubed is a good number. That's a number we should now have in our mind because it's helpful. It's vaguely reminiscent of a number we've used for a lot of immunosuppressive drugs over the years. But it feels in the modern age an unsatisfactory way of judging immune competence and functionality. I don't know what you think about that, because it's an absolute number rather than are the number that are they really, really good.
Absolutely. So I'm also wondering whether we really need more data, that we need more data on more patients, or that we need more data on a limited number of patients, but those data going deeper to tell us more about the function of these cells and not just counting them. Because this is rather a gross measure, I'm afraid. And it's not helping us to understand what's going on exactly.
No, absolutely. I mean, the authors would probably say in their defense, well, everybody measures a lymphocyte count in routine monitoring, so it's an easy measure.
Easier to do, absolutely.
And in that respect, to those of you listening, at least let's do this. Let's use a numerical cutoff. So there's no issue there. But I think what Hans is saying, and I certainly agree with him, this should prompt further evaluation. And I think there are now in a number of disciplines, in hem-oncology, in transplant medicine, in infectious diseases, and in primary immune deficiencies, secondary immune deficiencies, and I think across the immune-mediated inflammatory disease spectrum, we really need to be reflecting very carefully on how we evaluate the functional competence of immune-diseased patients. And it's complicated because we put these different interventions in. Anyhow, these are just the idle thoughts that came to mind as I read the paper and as I listened to your summary, Hans. Any final thoughts you want to share with us on these papers?
Well, these studies have been done in Japanese patients. And the question is, of course, is that also related to the genetic backgrounds of the Japanese people? Or is it broader, and is it just that they are ahead of many of other people that they have made the data available?
Yeah.
So that's also an interesting point to have a look at.
Yeah, and we're well aware that there are genetically driven changes and differences in the way in which immune infectious insult interact, and I think it's rather important that we bear that in mind. That's a great point. Well, look, time requires us to draw this podcast to conclusion, Professor Bijlsma. As always, an absolute pleasure. And to those of you who have been listening in, please pop along to see the publications that we've talked about. They're uploaded this month, and to see all the other podcasts and resources at imidforum.com, imidforum, all one word, .com. And don't forget to subscribe to the Immune-Mediated Inflammatory Disease Forum podcast channel. Make sure you don't miss our podcasts in the future. And as always, please do make sure to let us know what you think. Leave a review, tell us what works, tell us what you'd like us to do next time. Thank you so much for your attention. And of course, above all else, we do hope this information is helpful to you in looking after your patients. That's what the forum is all about. It's about improving the outcomes for people with immune-mediated disease and to allow us as health professionals to make the best decisions for and on behalf of and with those people who are at the center of it all, our patients. So Hans, many, many thanks. Great to see you today. Wonderful stuff. And to all of our folk who've joined us, very best of luck. Hope you are remaining well, and we'll see you next podcast. Thanks very much.